So when looking at consolidation, we could talk about its distribution. So some of the distributions that we can see on CT are a Lobar distribution, so affecting an entire lobe. We could also see a kind of a patchy distribution, meaning that it's kind of scattered throughout the lung parenchyma. It's not Lobar, but it's kind of patchy and scattered throughout. We could also see kind of a diffuse pattern of consolidation, that is, the majority of the lung is consolidated or opacified. Or we could have peripheral consolidation, meaning that the majority of the consolidation is located out towards the pleural edges. That's what we say is a peripheral consolidation. Here are two patterns of lobar consolidation. So for the chest x-ray on the right, we can see that there's a large opacity within the right upper lobe. We know that this opacity is within the lung because we see the presence of air bronchograms. We see these loosened branching structures running through the opacity. This tells us that we have air-filled bronchi running through an area of opacified lung parenchyma, and this typically means that we're looking at an area of consolidation. Sometimes we can see this with atelectasis, though we look for features of volume loss. We'd hope to see some movement of the fissures. So in this case, we're looking at a lobar area of consolidation within the right upper lobe. On the right, we're seeing a very similar pattern on CT. We can see that there's a large area of lung parenchymal opacity, that the lung is now rendered solid. We can see that it obscures underlying bronchovascular markings. And we could also note, like we had mentioned earlier, that there's a little bit of mass effect here on the fissure. We can see how the fissure is bowed slightly posteriorly, and that's not uncommon for consolidation to do that. So these are two patterns of lobar consolidation. They're largely confined to a lobe within the lung. So what is our differential for acute lobar consolidation? Well, the most common cause of this is the first thing you should always think about when you see consolidation in the lung is a lobar pneumonia. And typically lobar pneumonias are bacterial in origin. One of the most common causes for a lobar pneumonia is streptococcus. In addition, we can see this with aspiration. So aspiration producing a lobar pattern of consolidation, we'd expect that consolidation to be located within the lower lobes. It's an important thing to bring up if you see lower lobe consolidation, because if the patient does have an aspiration event, then leads to development of pneumonia, that'll change the antibiotic coverage that the patient is placed on. Certainly one of the things you want to think about for lower lobe lobar consolidation is aspiration. One of the things that's frequently overlooked as a cause of lobar consolidation is an infarct. So an infarct is typically the result of pulmonary arterial occlusion, although you can also have venous infarctions. This is actually what the case is on the right. This is a case of a pulmonary infarct producing a lobar area of consolidation within the right middle lobe. This is the lobar area of consolidation. If we notice, we can see that there is a filling defect here within one of the pulmonary arteries, and we can also see that the pulmonary arteries within the right middle lobe are completely occluded. So we're looking at an occlusive pulmonary emboli leading to a right middle lobe pulmonary infarction. So an infarct is a frequently overlooked cause for an area of lobar consolidation in the acute clinical setting. In addition, pulmonary edema is not going to be one of the first things that we think about when we see an area of lobar consolidation. There are one or two specific scenarios where we could raise the possibility of pulmonary edema producing lobar consolidation. The first being after a myocardial infarction that leads to mitral regurgitation. When you develop mitral regurgitation, severe acute mitral regurgitation, it causes a jet stream of blood that results in opacification located within the right upper lobe. So if you were to see right upper lobe lobar consolidation in the setting of an acute myocardial infarction, that could absolutely be an unusual pattern of pulmonary edema. This has been well reported in the literature. Another place you could see lobar consolidation as the result of pulmonary edema is with re-expansion pulmonary edema. So re-expansion pulmonary edema. So when does that happen? So these are people that say have a large right pleural effusion. The right pleural effusion is rapidly drained, and that lung then rapidly re-expands. And because it's re-expanding rapidly, it can produce extensive pulmonary edema within that lobe. And this edema that we see in the setting of re-expansion pulmonary edema can be very consolidated appearing. It can be very confusing to differentiate it from pneumonia or aspiration if you don't look at, say, prior chest radiographs that show that there was a large pleural effusion, and then a day later that effusion has been drained, and now they have all this opacity there. And so one of the causes of lobar consolidation is re-expansion pulmonary edema. So the two scenarios in which pulmonary edema can do this is with myocardial infarcts, leading to much regurgitation and right upper lobe consolidation. It's really the right upper lobe, as well as re-expansion in pulmonary edema. So what about chronic lobar consolidation? Chronic lobar consolidation, the big thing that you have to think about here, so you have an unresolving consolidation, is the presence of a tumor, right? And so a tumor can do this in two ways. One way is that it could be obstructing an airway, leading to post-obstructive pneumonia, which is not going to go away because the airway is not open. Or you're looking at one of the tumors that can produce a pattern of consolidation. And remember, the two tumors that can do this are adenocarcinoma and lymphoma. So those are certainly the things that you would want to think about for a chronic lobar consolidation. This is going to be your diagnosis of exclusion when you see this. And this is what this case was on the right. This is a case of pulmonary adenocarcinoma producing an area of lobar consolidation within the right lower lobe. Again, it's going to be a hard diagnosis to make when you first start looking at these cases. But certainly, this is one of the things that should come to the top of your differential when you have an area of unresolving lobar consolidation. One of the other biggest things I want you to think about when you see a persistent area of lobar consolidation is organizing pneumonia. Organizing pneumonia is a very common cause for persistent chronic consolidation, and it can produce a lobar pattern. And there are some unusual things that we can see this with, so atypical infections, like fungal infections. There's also an entity known as lipoid pneumonia, which we'll talk about a little bit later. But the big ones that I want you to really put in the back of your head here are going to be tumor and organizing pneumonia. Those are the two big ones producing a chronic lobar area of consolidation. Okay, so let's talk about patchy consolidation. So here we have a chest x-ray on the right and a CT on the left. These are two different patients. On the chest x-ray on the right, you can see that there are patchy areas of consolidation within the lung, mainly on the right side. Different patient with the CT, you can see that there's areas of consolidation, again within the lung. There's also some areas of ground glass opacity. We'll talk about that in a little bit. And again, it shouldn't surprise you that you see areas of ground glass opacity in the lung when you have consolidation, because really ground glass opacity could just represent an incomplete consolidation, right? The lung is just partially filled up with stuff, where the consolidation represents total filling at the alveoli. So it's not uncommon to have consolidation and ground glass coexisting together. But in either case, we would say that this is a patchy pattern of consolidation. We see patches of consolidation within the lungs bilaterally in the CT and then unilaterally on the right. So when we have patchy consolidation in the acute setting, the differential here doesn't really change much from lobar consolidation. The two big ones here that we're going to think about again are pneumonia and aspiration. So with pneumonia, again, it can be kind of located anywhere. Bronchopneumonias are not uncommonly patchy. They're peribronchial in distribution. Aspiration, again, we'd expect it to be more in the dependent portions of the lung. This is actually a case of aspiration. So this is a case of aspiration. And we can see that, again, there's patchy areas of consolidation within the lung. They're peribronchial in location. There's some adjacent ground glass opacities, which, again, we expect when we have kind of an acute inflammatory process like this. The alveoli are incompletely filled. And the clue here, I don't know if you guys have noticed this yet, is that if we look at the esophagus, right, the esophagus is very fluid-filled. When you have a very fluid-filled esophagus like this, it places the patient at risk for aspiration. That's what happened in this case. The patient aspirated the contents that was in their esophagus, producing these patchy areas of consolidation and ground glass opacity within the lung. Now, patchy consolidation can also be perihilar in distribution. When we see perihilar patchy consolidation, the differential kind of changes a little bit. It's harder to come down firmer on a particular entity. So again, when we see consolidation, one of the things that we always want to consider is pneumonia. But when it's perihilar like this, you want to also think about pulmonary edema, diffuse alveolar damage, as well as hemorrhage. Diffuse alveolar hemorrhage can produce perihilar consolidation. So we have two cases over here, and I think that we can agree that the consolidation that we're seeing is adjacent to the hilar structures. Right? It's predominantly centrally located within the lung. Now, the question becomes what is going on here? So we could use some clues. So when we see bilateral pleural effusions like this, bilateral pleural effusions, one of the things that we certainly would want to consider is pulmonary edema. And that's what this ended up being. This is pulmonary edema. So you can see how pulmonary edema can produce a pattern of consolidation within the lung. The consolidated pattern of pulmonary edema more typically occurs not in people with congestive heart failure, but usually in people that are going through rapid heart failure. So rapid volume overload. So people that are in acute renal failure, rapid volume resuscitation, non-cardiogenic pulmonary edema. Those patterns of pulmonary edema can produce this kind of perihilar batwing pattern of consolidation that can produce this consolidation that we're seeing. On the other hand, we can see that this case looks fairly similar to the case of pulmonary edema. This actually was a case of mycoplasma pneumonia. We actually have fairly symmetric perihilar areas of consolidation and some ground glass opacity. When we just compare these two cases, there's not a lot of difference. You can see how you may have to give differential at some points if you don't have a good history. One of the clues that I like to use when I'm trying to distinguish between pneumonia and pulmonary edema is look to see if the consolidation and ground glass opacity goes all the way out to the pleural edges. If it goes all the way out to the pleural edges, it usually favors that you're either looking at some sort of acute lung injury process like diffuse alveolar damage, or you're looking at pneumonia. The rationale for this has to do with the lymphatics. So your lymphatics have an easy time pumping away blood and water. So blood and water are really easily cleared from the lung parenchyma. The lymphatics are really robust out towards the pleural edges. So notice in this case up here of the pulmonary edema, there's kind of like what looks like sparing of the outer edge of the lung, the cortex of the lung. And that cortex of the lung is spared because the lymphatics are rapidly pumping out fluid from that area, and so they don't become as consolidated as the central areas of the lung. When you compare this to, say, like pneumonia, like we have in this case down here, we can see that the opacities go all the way out to the lung edges. When opacities do this, when they go all the way out to the lung edges, give favor that you're looking at some sort of exudative process, okay, an exudative process like pneumonia. So that's one helpful clue that I use to try to distinguish between pulmonary edema and pneumonia. You could also use secondary signs that we talked about, such as bilateral pleural effusions. You could look for septal thickening, which we'll talk about, and big heart. Those things would all favor pulmonary edema. But again, sometimes it can be really difficult to differentiate between these two entities. You have to use clinical history. Is the patient volume overloaded? Are they in acute renal failure? Are they febrile? And what is the white count? So let's talk about patchy chronic consolidations. So patchy chronic consolidation, so again, we're dealing with the process that's subacute or chronic or persistent. So meaning that we have initial CT, we thought it was maybe pneumonia, and now these consolidations have persisted or have gotten worse. So the big ones that we'd want to think about here are organizing pneumonia, vasculitis, as well as lymphoma. Okay, so some of the tumors can actually do this as well. So we have two cases where we can see that there's these areas of patchy consolidation within the lung parenchyma. The case at the top actually ended up being primary pulmonary lymphoma. And you can see how you can easily confuse this potentially with pneumonia when you first start looking at these cases. The case in the bottom was a case of organizing pneumonia. So you can see how there's a lot of similarity between these two cases. It can be difficult to differentiate between these entities, and it may require a biopsy. And in fact, a lot of the time when you have chronic consolidation like this, these will go on to a biopsy. Let's talk now about peripheral consolidation. So what do we mean by peripheral consolidation? It's pretty straightforward. It's when consolidation is located in the periphery of the lung, and we have some examples of that here. So you can see that there's consolidations and opacities located out in the cortex of the lung, so all the way out in the periphery of the lung parenchyma. We want to reserve the term peripheral consolidations for when we have opacities that are exclusively located or the vast majority of them are located out in the periphery of the lung. We're not talking about, we don't want to bring in the differential of peripheral consolidation if we have like multifocal opacities throughout the lung and, some of which are located out in the periphery. We're talking about cases like these, where the vast majority of the consolidation or virtually all of the parenchymal abnormality is located out in the periphery of the lung parenchyma. Okay, so what is our differential for peripheral consolidations? Well, again, we have to first start with, is it acute or chronic? So if it's acute peripheral consolidations, the big ones that we want to think about here are infarcts, pulmonary contusions, and of course pneumonia. It's not, pneumonia is such a common entity in the acute setting. It's something that we should always kind of keep on our differential. When it's chronic, the big ones that we want to talk about are organizing pneumonia and chronic eosinophilic pneumonia. These are the two that should kind of just roll off of your tongue. When someone tells you that you're looking at chronic peripheral consolidations, the first things that should come to your head is organizing pneumonia and chronic eosinophilic pneumonia. Now, some of the vasculitides, particularly Church-Strauss, can produce chronic peripheral consolidations. And again, do not forget about the infamous adenocarcinoma. So adenocarcinoma, do not forget about tumor producing chronic consolidation. So you always want to keep that in the back of your head there. Okay, so on the right, we can see that there's two cases of peripheral consolidation. We can see that the opacities are out in the lung edges. And these opacities look pretty similar. These are completely two different cases. The case in the top actually represented pulmonary infarcts. This is a person that had pulmonary emboli, and the lung was infarcting. The case in the bottom actually reflected organizing pneumonia. And you can see how there's a lot of imaging overlap here. You really have to know what's going on with the patient. On the top, if this person is coming into the emergency department, they have chest pain, short of breath, tachycardic, you have to consider that these are infarcts. Even if this person doesn't have contrast on board, it's not even a PE study, one of the things that you would always want to say is that these potentially could represent infarcts. Perhaps this patient needs to get a CPA. If they can't get a CPA, maybe they should check the lower extremities for DVT. On the bottom, organizing pneumonia is going to be a little bit different, right? These are more kind of subacute chronic symptoms. So chronic cough, fever, weight loss, over a prolonged couple of weeks. You often will have a history of a drug toxicity or something like that, in which case you can consider organizing pneumonia. So let's talk about diffuse consolidation. So we want to reserve the term diffuse consolidation when the lung is really diffusely involved with opacities. It's not just kind of, patchy opacities here and there. They're, diffusely affecting the lung. It's when the lung is just diffusely consolidated. It's largely opacified. And that's what we see in these two cases. We can see that the lung on the left and the lungs on the right are largely opacified. They're largely consolidated. The one on the right also has some ground glass opacity, which again is not unusual. So again, these are largely consolidated lungs. This is a pattern of diffuse consolidation. So then what can do this? So when we see diffuse consolidation, this is almost always the result of some sort of acute process. So the two big acute processes that we want to think about here are diffuse alveolar damage and pneumonia. So diffuse alveolar damage is essentially ARDS, and we'll see this pattern of just widespread consolidation. Uncommonly, pulmonary edema and hemorrhage can also do this. They can be hard to distinguish. Again, you have to use some clinical clues here to really differentiate between these entities. But the two big ones that I want you to think about are diffuse alveolar damage and pneumonia when you see extensive, widespread consolidation like this. This is actually a case of diffuse alveolar damage.